third wave Omicron with Delta, what's new? We have in this your health counter, where Heal Foundation and Heal Health founder and one of India's top health communication expert, Dr. Swadeep Srivastava, will be in conversation with top health experts. Heal Foundation and Heal Health, which have been at the forefront of healthcare awareness through healthcare communication, and has been instrumental in creating campaigns and platforms for healthcare improvements in India for the last 2 decades. He will be speaking with Padma Shri, Dr. Shashank Joshi, who occupies the Chair International Diabetic Federation Southeast Asia. He is a reputed endocrinologist at Joshi Clinic, Leelavati Hospital, and member COVID-19 Maharashtra State Task Force. Dr. Joshi is the president of two important organizations, the Indian Academy of Diabetes and Association of Physicians of India. He was also former president of Research Society for Study of Diabetes in India and the All India Association of Advancing Research in Obesity. He is the former vice president of Association of Physicians of India and is now its advisory board member. Long time I'm meeting you, Dr. Shashank. I think we met last in Delhi for almost more than 3 years back, and glad to see you back again here.
Welcome, Dr. Joshi. So today's topic, third wave Omicron with Delta, what's new? And I'll give the stage to you, sir, in terms of your perspective. With this in mind, that in the end, we would definitely have 3 to 4 very important questions before we answer. Is about the first is the perception of this Omicron coming and making this pandemic an endemic. Second is a lot of confusion and discussion around herd immunity theory. And third is about COVID pills overall generally, from most of them are under emergency use authorization. So what people should understand about, because there's so much of news going around on COVID pills which confuses the public at large. And most importantly, in the end would be, when would this COVID pandemic end?
Probably for the first 10-12 minutes, I'll share some slides. And probably in the next maybe another 5-7 minutes, take some of your questions. 2 things before I start any of my presentation are 2 caveats. First is, COVID is predictably unpredictable. And COVID science is a unpredictable science. Whatever science is done and is published, by that time that science gets published, the new variant has emerged or a new pattern has emerged. So science is always falling behind. For example, you mentioned your last question that there are some new age antiviral pills. Their research was done in unvaccinated population, and now we have a vaccinated population. So obviously the goalpost keeps changing all the time. So with those 2 caveats in mind, that COVID is predictably unpredictable and the goalpost in evidence-based space keeps changing, it allows a lot of speculation in era of evidence-based medicine. So I will try to share some slides and make things a little simplistic for everybody for 2 things. That we are in the third wave worldwide. Maybe there are more waves, but this wave is like a tsunami. And there are 2 camps, which Swadeep said. One is a camp called inevitability camp, and another camp is called as the avoidance camp. So the inevitability camp says, oh, this is a mild variant. This Omicron is a mild variant. The lung-to-lung cell virulence has 5 studies, but it's still mild. The vaccine infection, even if you have natural COVID, if you have taken the vaccine, there are T cells which hold up very well. So, it will protect you from severe disease. Even if you take an extra precautionary dose, it's immaterial because it's for a short duration. The long COVID, don't worry about it. This will just be like a natural infection, you'll be done with it. There are many new pills, but you don't need it really. And it's all about herd immunity. Okay, so this is actually your question, which Swadeep, I didn't know you would be asking this, but this was my first slide. But there is another camp which says it is less severe, it's not mild, it's less severe. So it's very, very important to recognize this thing. Hamsters, mice, culture dishes don't make people, So yes, Omicron is a nose and throat disease, but not a lung disease. While Delta is a lung disease and we have a little bit of both. Delta kills, Omicron is unlikely to kill. Okay, but remember that there is always many people who are aged or immunocompromised or cannot mount the immune response, including you and me. So we don't have an assured layer of defense. Okay. Then also, though we are taking extra doses, there are plenty of breakthrough infections. In fact, most of the Omicron which is occurring in Mumbai and Delhi today is the people who already had COVID in the past and already have had 2 doses. Okay, it's very important to know that there is a lot of long COVID there. And people, even after Omicron, we are in the 3rd to 4th week in Mumbai city. Even today morning, I was talking with a case of mine who is persistently having persistent fever and giddiness with a lot of fatigue and tiredness, feeling of drained out. So there is something called long COVID, which we can't dismiss even in Omicron. And pills are there. They have a role, but their role is limited and selected. And obviously it's a very transmissible, it's the most contagious virus probably. It's a new beast, the Omicron, and we need to contain it. We need to contain it very quick and fast. So this variant came with a lot of mutations. And this football-like virus had spikes. And the spikes have got really mutated. So 32 mutations on the spikes. And the attachment of these spikes in the lungs is through the ACE2 receptors. And that entry point also had 10 mutations. So both the entry point had 10 mutations and the spike had 32 mutations, 50 plus mutations. So obviously, and it originated in Africa, probably in Botswana, in an unvaccinated population, but moved to South Africa. And probably that beta, it was there probably when beta was around. But beta got replaced in South Africa very rapidly by delta. And now delta, in a span of 10 days in November, got replaced by Omicron. So it's all the story of Omicron, which is now ravaging worldwide, is between 11th November to 23rd November. So that's really the story of it. And it deletes the S gene. The virus has different structures. There's S gene, E gene, N gene, RF gene. So the S gene is deleted. So that's the easy way to find it out, to delineate it. So the old beta, gamma, delta was originating in India, gamma was originating in Brazil, beta was originating in South Africa, and then we have this new strain. So what are the issues? Is it more transmissible? Yes. It's a rapidly contagious virus. Does it immune escape? Which means if you had COVID or if you had vaccine, yes, it has immune escape, but it saves lives. Because the virulence is less. The severity is less. That's very clear. It may be less severe, but it is less. And initially it was sporadic or travel related. Now there is community transmission. So that is what we know. Rapidly transmitted, super mutant, R0 is unknown. It is replacing delta, but delta is still there. So when Sandeep told me to talk, I said there's still delta around in hinterlands of India, in large geographies of India, and we can't afford to miss that delta. So remember, if you have nose and throat COVID, a lot of sore throat, a lot of headache, backache, with a lot of fever, it's likely to be Omicron. But if you have lost taste or smell, if you are out of breath, and if you have a lung involvement, it is likely to be delta. And the delta is being replaced by Omicron, but there's still delta, 5, 10, 15% in different geographies. So it's going into a cluster wave. It's very contagious. Immune escape and breakthrough is there, but severity and virulence probably early is very less. So obviously, you saw this was the South African. They had the first wave with the Wuhan strain, second wave with the beta strain. Beta got replaced by delta, and delta got replaced by Omicron. So if you head-to-head compare delta and Omicron, you can see the mutations. This is a graphic picture of delta versus Omicron, and you can see it graphically. There's a big difference between delta and Omicron. Omicron is having a lot of mutations. You can see all those mutations. Okay, but it is an evolutionary virus. So it transmits fast, it evades immunity fast, but probably the disease it causes is more localized in the nose and throat and upper airway. While delta has less mutations, also transmits faster than the original strain, but goes deep down into the lungs and can cause you hypoxic, make you breathless, and can kill you. So that's really the difference. Well, for us in India, we have a single target: 0 COVID deaths and less severe disease. And this was what I wrote in May 2020, when the first wave was there, that we need to identify people in India who are vulnerable and at risk to die. So people who are above 50, 55, male gender, hypertension, diabetes, obesity, chronic heart disease, chronic lung disease or asthma, chronic kidney disease or liver disease, any congenital or acquired immunodeficient state, or users of steroid, immunosuppressants or transplant recipients. This is our high risk group. This is the population to protect. This is the population to save lives. This is the population to red flag or highlight, or any disease, any serious illness you may suffer from. Whether you are an adult or a child, they need to save their lives. So obviously we need to pick up these and save them from hospitalization. Whether it is a Delta, whether it is a Omicron, Omicron is less severe, Delta is more severe. But if you are asthmatic, if you are hypertensive, if you have obesity, if you have diabetes, if you have chronic kidney disease, if you have severe obesity, or 2 or 3 of these conditions, your risk of hospitalization and death goes up significantly. And this is a rapidly transmissible strain. It has a viral competitive advantage. It is 500-fold viral competitive compared to a Delta or a original strain. So clearly, its lineage has now 2 lineages, BA1 and BA2. So there are 2 sub-lineages. In Calcutta, 80% is the lineage 2, which may duck the RT-PCR test sometimes. And these both lineages really don't matter because they are very contagious. So transmissibility is the highest, disease severity is low, and escape from vaccine or natural infection is the highest. So there are 3 types of COVID we see in practice today. One is people who are completely unvaccinated and no past COVID-19. They are at highest of this. So somebody, very rarely we find this now. In Mumbai city or Delhi, we rarely find it, but in hinterland we'll find it. And even in Delhi and Mumbai, we still see such patients, which means they have never received a single vaccine, never got COVID in the past. This is called COVID first infection. They also are at high risk because they don't have a exposure to the virus. Then we have breakthrough. This is the commonest group which we see, which means they have either had 1 dose of vaccine, 2 doses of vaccine, or even they have taken a booster, or COVID reinfection, which means they had infection in first or second wave, they have got reinfected, or a mixture of both. So this is what we are seeing in our population every day. This was the old timetable. 80% had no or mild symptoms, 14% had severe symptoms, 5% received ICU care. This was the Delta pattern or the Wuhan pattern. What is the Omicron pattern? Well, the mild disease or asymptomatic disease has moved from 80% to 95%. The severe disease has moved from 14 to 4%. And the ICU has moved from 5 to 1%. So this is the big change today, that as the virus has evolved, it has become less sinister. And but you still need to distinguish both, because you still need to save lives. And that's the challenge we have as doctors. Most of us as human beings have a very robust immune system response. So we'll clear by very good interferon, by Th1 cells, which are T helper cells, by very good B cells, which make neutralizing antibodies. But the unfortunate vulnerable few won't have an immunity response. They will falter, they will not make interferon in their body, their T cells will get exhausted, their natural killer cells will get exhausted, and they'll accumulate negative chemicals for cytokines, and they'll get a cytokine storm. So there are 3 stages of the disease. 95% of current COVID will be in the early stage, which means mild, asymptomatic. But if there is persistent fever, persistent cough, you need to red flag. Persistent fever, persistent cough, if you have breathlessness, you need to red flag. The second stage is lung phase. There is virus. If the lung is affected, clearly it is likely to be a Delta. There are opacities, there are glass opacities, and then of course the body's immunity becomes hyperinflammatory. You get cytokine storm. So obviously we still need, as Swadeep rightly said, oral antivirals and immunomodulatory agents. But we are in an era of evidence-based medicine. And in evidence-based medicine, in the COVID era, the recommendations are A, B, and C. Strong recommendation, moderate recommendation, optional. And the rating of evidence is 1, 2A, 2B, and 3. So 3 is expert opinion, 2B is non-randomized or observational studies, 2A are randomized trials or subgroup analysis of randomized trials, and 1 is randomized trials without major limitations. So that's how it has been highlighted. The easiest test to do is don't run for too many tests. You can just do a CBC or a simple complete blood count. If the IDW is more than 14.5, you could be likely to deteriorate or become severe, or if the new NLR or CRP. Occasionally we do LDH or D-dimer or ferritin, but that is with doctor's discretion. So COVID-7 is very simple. Monitor for fever. If the fever is more than 100 for the next 3 days, put him in the hospital. But paracetamol is the drug of choice, and keep giving paracetamol 500 to 650 milligram 2, 3, 4, 5 times a day. No problem. If your pulse rate is very high and inappropriately high, you probably need to be in the hospital. If your respiratory rate is high and you are out of breath, you need to be in the hospital. If your sugar and blood pressure needs monitoring, and connected with your doctor. But the COVID stethoscope is still, whether it is Delta, whether it is Omicron, is still the pulse oximeter. Oxygen saturation is the key. Measure the pulse oximeter properly, saturation. If it is not, after, then do a 6-minute walk test. And if it is still perfect, there is no drop of 3% or it's not below 93%, you are good to go, and be connected with the patient. Now, more important thing is, because we rely at home isolation, everything is on pulse oximeter. So person should be resting without a mask, breathing quietly and not talking for some time before you do pulse oximeter. Warm the fingers because it's very, very cold in lot of parts of India, and ensure that you use a middle and ring finger, right? Don't use a nail polished finger. Cold extremity should be warm, and wait for a 60 seconds before you see the pulse oximeter readings. It's still the key. You still can miss an occasional Delta. So the new COVID of Omicron is 7 to 14 days. Most people will become okay in 7 days, otherwise they need hospitalization. The old timetable was 14 to 21 days. But after COVID, for 3 months, you need to be vigilant. You must, if you have comorbidity like blood pressure, heart disease, kidney disease, diabetes, you need to monitor. Right approach, right time, right medicines. There is no need to give antibiotics, antimicrobials, antiparasitic agents arbitrarily unless your doctor feels there is a secondary infection. Always insist to talk to patients on phone, and don't forget to give life-saving drugs like an antiplatelet drug, a statin or anticoagulant, high-risk cases, because we still are the cardiometabolic capital of the world. Well, sometimes we give persistent cough, we give inhaled steroids. But we need to identify who is dying. So senior citizens, people with lung, heart, diabetes, obesity, chronic kidney disease, immunocompromised and transplant people are the ones. So the very high risk populations are these 5. And we need to save their lives. People who are solid organ transplants, people who have blood cancer or active chemotherapy patients, people who are on dialysis, immunosuppressive therapy or immunodeficient people. These are most likely to die. And that is where these new age therapies come in the picture, like an antiviral therapy or an antibody therapy, which has become very popular, but you need to delineate it. If it's a Delta, they will definitely work. If you don't have immunity, which means you are behaving like an unvaccinated population, that means your immune response is poor. For example, a lot of people have a spike protein which is positive, but a nucleocapsid antibody or virus neutralization test is negative, then that means they have weak immunity, or they are behaving like unvaccinated population. That is where an antibody therapy will work if it's a Delta, if there's lung involvement, or an antiviral drug may work. So this is something which we need to recognize. So remember, home isolation is the key. And Government of India has done excellent guidelines now on home isolation. And only for people who are elderly, above 60, with hypertension, diabetes, heart, chronic liver, lung disease, kidney disease, cerebrovascular disease, will only be there if the doctor feels they should be home. Otherwise, home isolation is still the key. Isolate yourself in a well-ventilated room. Try to use the proper triple-layer mask. Discard mask after 8 hours. Cut out the mask. If there's a caregiver, use N95. Rest and hydrate. Sleep for a good 8 hours. Maintain some respiratory etiquette. Do not share your personal belongings. And keep monitoring your temperature and saturation. You must take your medicines for comorbidities. You must do teleconsultation. If symptomatic management of fever, running nose and cough is warranted, do warm water gargles and steam inhalation. Paracetamol 650 milligram 4 times a day. Do not get misinformation by social media. And I think I congratulate Heal Foundation for last 20 years. Swadeep, Shankar and your whole team. Swadeep, you have been doing excellent service to humanity in general and Indian community in general, because you have given the right information. Because there is no need to panic, to do unnecessary tests and treatments. Do not rush for self-medication, blood test or X-ray or CT scan, unless your doctor feels it is needed. Steroids are not indicated for mild disease. It should not be self-administered. And treatment should be monitored, for each individual is different. So it's very, very important to recognize that who should we admit. This is the most important slide. Okay, if somebody has difficulty in breathing, somebody has high temperature for more than 100 degrees for 3 days, somebody's saturation is dropping down below 93%, at least 3 readings within 1 hour, or the heart respiratory rate, person is breathless, more than 24. There is persistent pain or pressure on the chest. Person is confused or person cannot be aroused. There is severe fatigue and myalgia. If any of these 6 conditions are there, please admit the patient. There is no harm, because these are the people who need admission. Every life matters. When to discontinue? Probably, we know now that if person is asymptomatic for 3 days, no fever, okay, you can release them from self-isolation after 7 days. So there has been a lot of changes in the guidelines, in the discharge policies for mild cases. But if there are moderate cases or severe cases, the old dictum still stands. And obviously there are excellent guidelines now for turnaround time for healthcare workers and so on and so forth. So I will stop here probably, but there are 2-3 things which I want to say. One is about monoclonal antibodies, second is about molnupiravir, and third is about the vaccinations. Because the monoclonal antibody is very good for it's a life-saving treatment for Delta, or if the lung is involved. So your doctor might decide it's a good option to give. It's a level A evidence, and this cocktail antibody, which was given for President Trump, was in the Delta wave, is very useful, and also for caregiver for prophylaxis. So excellent data available. Omicron data is not available, but it's unknown. So it is not banned, but it's unknown. So right now we say if you are suspecting a Delta, it's good. If you are suspecting Omicron, it's unlikely to respond. So there are a lot of other antibodies which are coming up also, which might have, like sotrovimab or the other antibodies, which may have a role in Omicron. So antibody in Omicron world, if it's a Delta or if there's lung involvement, they may have a role. Otherwise, the role is limited now. As far as the molnupiravir has been concerned, and the new age agent, the nirmatrelvir and ritonavir is concerned, yes, it may have a role, okay, because it's a chain terminator. Okay, so if somebody has persistent fever for more than 2 days, okay, and you are above 50, and you have more than 2 or 3 comorbidities, your doctor might give you this agent. So there is nothing to get worried. We don't give it for children below 18. We don't give it for people who need hospitalization. We don't give it for people with childbearing potential. And it has very good data. Mind you, the trial was prematurely terminated because when Merck was doing the trial in the US and it has publication in the New Journal of Medicine, the people felt that the placebo group, were denied of the population, and it clears the virus in 3 days. So very, very good data on molnupiravir. I do not 30% reduction or absolute relative risk reduction of 3%, but social media is very gung-ho about it. No drug-to-drug interactions, but avoid it in pregnancy, lactation, and pediatric patients, and has impact on Omicron and Delta both. So it's a very good broad spectrum antiviral. It has an EUA in UK, USA, Japan, Denmark, Philippines, and India. It reduces hospitalization and death by 30%. It improves clinically patients, but use it in people who deserve it the most. Then, of course, this new agent is very good. It's not available in India, so I'm skipping it. It's called as the ritonavir boosted therapy. Again, in high-risk groups, it's very good. So if you summarize the antibody, the molnupiravir, the Pfizer pill, you need to start them early, hit hard, hit early. You have to give them in the first 72 hours. They reduce hospitalization from 10 to 3%, monoclonal antibody, molnupiravir from 10 to 7%, only 3%, and the Pfizer pill by 7 to 1%. But the efficacy on hospitalization and death is 70%, 30%, and 85%. Obviously, remdesivir has come back. There is a 3-day study in remdesivir, which can be very, very useful in outpatients for 3 days, which can clear the virus quick and fast. And then, of course, we have these new age agents which we give, tocilizumab, itolizumab, which also can have their own challenges. But remember, and steroids. Asymptomatic Omicron, comorbidities or no comorbidities, observe, no blood test, no treatment. If you're not symptomatic, you don't need anything. Don't even test, don't even treat, observation is the key. If you're symptomatic without fever, which means just a nose and throat and cough, but you have comorbidities, you might sometimes need symptomatic treatment like a cough inhaler under medical supervision. If there are no comorbidities, again, you might just need symptomatic treatment, which means paracetamol becomes the treatment of choice. But if you're symptomatic with fever and you have no comorbidities and you are probably above 60 years of age, one may be offered molnupiravir. If you have no comorbidities and less than 60 years of age, paracetamol and symptomatic treatment, you can give molnupiravir, but it's at individual discussion. And then, of course, if you are symptomatic with lot of comorbidities, then either you admit the patient and give remdesivir, or you might sometimes have to give other options. So there are a lot of these options which are there. Delta variant, the monoclonal works. Omicron variant, it's molnupiravir, remdesivir may have a role. And in hospitalization patients, remdesivir works. This is what is the current age. But our whole idea is to save lives. We want to get zero COVID deaths. We don't want severe disease. We want ultimately COVID to become a mild, manageable, endemic disease like dengue and malaria. And maybe Omicron is a change. So, what I have tried to do here is summarize some things that we need to be responsible. And on 16th of Jan, as we talk, Swadeep, in this whole COVID-19 treatment conundrum, we definitely need to save every life. For me, if you ask me, saving every life, saving people from severe disease is the key in COVID management today. And that's our medical focus, if you ask me. And for that, outside in the community, you just had a beautiful panel which said, double mask, air ventilation, that's the key. And when you unmask, be alone. It's better that you and me have a cup of tea at our respective houses rather than sitting in front of each other, or have a little bit of idli with shankar. But that's the key. Okay, meet digitally or virtually. Okay, and not physically for some time. And the disease will get endemic. We are heading for endemicity. I don't know that herd immunity concept has been faltered and broken through. All the walls have been broken by Omicron. But that doesn't mean that we are not protected or safe. Also remember, US, Europe is ravaging with a pandemic of the unvaccinated, with a lot of Delta there, which is why the deaths are very high there. While in India, the replacement of Omicron of Delta by Omicron has been very rapid because the Delta has already gone away. See, when the wave has hit India, okay, the Delta had already moved out in most geographies, except probably Kerala, Maharashtra, Northeast India. Most places like Delhi, the full Delta had gone. So we got fresh Omicron. While when the Omicron landed in Europe and USA, they landed when Delta was also there. So they got a double whammy. And that is why they are seeing very large numbers and large deaths. That's the truth of science as it stands today. As I said, I have tried to be as evidence-based as possible. Okay, but these are areas, as I said, we are learning every day from this new virus. The human body is as smart as the virus, and the war will continue. But every new strain, probably the virus is evolving to be a milder one. That's the evolution of pandemics. If you see history from Spanish flu, then ultimately we still have flu around. We still get flu today, but we can manage flu. We have a vaccine for flu and we can still manage flu. And hopefully, let's hope that though COVID, we may have to live with it, we will be able to be making it as a mild manageable disease. And we need to have zero COVID deaths. That's really the current aim for all of us.
So, sir, when you talked about COVID pills, sir, like starting from, because most of these COVID pills are under emergency use authorization. So first, particularly from a general public point of view, what would this mean, emergency use authorization from their perspective, what they should understand about it? Second would be like so many guidelines and counter opinions coming on pills. So how much people should actually absorb and believe? Say in case of even you just spoke about molnupiravir, and that has started with remdesivir also earlier. When remdesivir started, WHO gave a different statement, and then now it is in regular practice by the practitioners are saying. So there is always also a clash of opinion between the researchers, scientists, and the practicing doctors who are seeing something else or some better benefits while they're treating patients, particularly when limited options are available, sir. So how can you answer this, particularly what people should know about emergency use authorizations?
See, all drugs, normally a drug takes a couple of years. Vaccines also take a couple of years to work. So whether it is a drug or a vaccine, these are all early use and rapidly developed vaccines. Normally, if you see in the history of medicine, vaccines took 8-10 years to develop or 20 years to develop. Similarly, for any new therapy to come, it takes a couple of years to develop. So obviously, these are all repurposed drugs which have been used overnight. But the data generated, as I said, has been reasonably robust. And the new age pills which are coming in, whether it is the latest data on remdesivir, the latest data on molnupiravir, that is saving lives. See, we started with the story of hydroxychloroquine, ivermectin, and the early remdesivir days when there was no data. So we started with nothing, and only we found out that dexamethasone worked only in severe cases, and oxygen and prone position and nursing care. So that is how therapy evolves. So when we have a new disease which is evolving with new strains, obviously we will have new age agents. We have to choose the most vulnerable group. So for me, as a treating doctor, it's a very simple algorithm. Look, for lay people, they should go by their doctor's advice, because every patient is different and the profile of every patient is different. So if somebody is asymptomatic, is 85 years old, has just mild hypertension treated with one tablet, completely asymptomatic, CBC, CRP, nothing is needed. You just need observation. You need temperature monitoring and saturation monitoring. But the same 85-year-old has a little bit of kidney issue, has hypertension, diabetes, which is very high, probably, and is symptomatic with persistent fever of 100 and above, probably will need, if can be managed at home, an oral pill, or may need to go to a hospital and need an injection. So every case is different. For me, who is most likely to die? For me, every human life is important. So the idea of using these patients and these pills are in the most vulnerable groups. Unfortunately, what happens is, lay people feel that this is like a magic pill and the pill gets used indiscriminately. And that's where the Lakshman Rekha has to be drawn by the treating doctors as well as the lay people, to draw a line that if my doctor is saying that this pill is not good for you, this injection is not good for you, you don't need to take it. That's where we really need to self-regulate, which is why I think I must admire Government of India has been very prudent, but their approach has been very socialistic in nature for most of the people, most of the time. While for us as clinicians, for every person living with COVID matters, and every life is equally important. So saving that life in the vulnerable group who's likely to deteriorate definitely matters. And if there's data and evidence to show that it might be saving lives, and all these newer therapies definitely have data to show that at least in the Delta variant, they save lives. So if there's lung involvement, they save lives. If there's just a nose and throat COVID, see what is the Omicron today? It's predominantly a bad sore throat. And if it's a bad sore throat, I think, it's a little more worse sore throat with fatigue. Most people will do very well, whether you treat them or you don't treat them. It's symptomatic treatment. Let me be very transparent. I know pharmaceutical industry may not like what I'm saying, but I must compliment them that they have got these therapies to save people who are most at risk to die. And that is where you should use it. So I think we need to really know when to use, what works, in whom it works, how it works.